See, we have a good amount of people joining us today. Thank you all so much. Looks like everyone is well connected. So we'll go ahead and get started. Again, good evening. My name is Nina Barrientos. I am the GME Program Coordinator here at the Office of Graduate Medical Education. With me, I have Miss Melody Portillo. Melody is in our Careers in Medicine office. She is the Program Coordinator. And facilitating this evening is going to be Dr. Stanley Fish. Everyone's familiar with Dr. Fish. She's such an amazing human being. He is our Associate Dean for Student Affairs and as well as a Professor for Pediatrics. Just a few general housekeeping rules is to please remain muted unless prompted. Please use the chat box feature for any questions, and Melody and I will help assist by either answering or letting our presenters know that there are questions for them to review. This session is being recorded for recruitment purposes for our programs. And if you should have any questions, please feel free to reach out. And I will now hand this off to Dr. Fish.
Thank you. Welcome, everybody. And this is I think our third residency fair. The first one was a live event 2 years ago, and last year we were virtual like this, and now we're virtual again, but next year we hope to be live again. But in any case, we're glad that you're all here and that we're able to do this. Our purpose this evening is to really showcase the residency programs affiliated with our school that are located here in the Valley, and the Driscoll program in pediatrics, with which we also have a close relationship. We will cover several programs this evening and follow up next week with 2 other sessions covering the rest of the programs. For those of you students who are in your 3rd or 4th year especially, this will be, a chance to, do a little more in-depth learning about the programs that we have here in the Valley. For students who are in 1st or 2nd year, you'll learn that, but I think more fundamentally, you'll have a sense of what graduate medical education is all about. Our programs are relatively new and are certainly representative of the types of programs that exist in their fields around the country. Every program is different, of course, and located in different locations. And so each program has a different set of priorities, set of interests, and of course, many different kinds of patient care responsibilities, research activities, and community involvements. And so by kind of reviewing each of our programs, I think you'll get a sense of the variety of ways that programs, even in the same region here in the Valley, but the variety of ways in which programs organize themselves and relate to their mission of training future physicians while serving the community and advancing the science of medicine. So with all that, I'd first like to give a chance to welcome Dr. Daniel Albo, who is with us. Dr. Albo is the chair of the Department of Surgery, surgery here at UTRGV. Dr. Albo, if you'd like to say a few words of welcome and encouragement tonight.
Oh, thank you, sir. Can you hear me well?
Yes.
Fantastic. Thank you for having me, and welcome everyone. Welcome to a beautiful Rio Grande Valley. I'm the new chair of the Department of Surgery, a relatively newcomer here to the school. I started here in June, and perhaps I should start right there to tell you why I think you should come here. Is exactly why I decided that it was time for me to come here and bring my family here. This is an extraordinary part of the country, a beautiful part of the country, with a medical school that is coming literally off the ground, supported by one of the largest university systems in the country, the University of Texas system. It has a very unique mission imperative, which is to provide the highest levels of healthcare for very large geographic area. The Rio Grande Valley is one of the fastest growing areas in Texas. And it has the mission imperative of providing medical education. We're the sole providers of medical education for all of our future leaders in healthcare for South Texas and beyond. In surgery in particular, there is a tremendous amount of energy and great things happening. We have an embarrassment of riches, really. We have not one, but two residency training programs, one in the Upper Valley, centered around DHR, and one in the Mid and Lower Valley, centered around Valley Baptist Health. And these two are terrific programs where you can expect the most advanced surgical training in the most advanced surgical techniques, in particularly emphasis on minimally invasive surgery.
Thank you.
We are building one of the most sophisticated surgical simulation training labs in the country, right here in the Valley. There is very unique providers in the large case volumes and direct exposure to our surgeons in all three components of the Valley that I think would make for a very diverse, very enriching surgical education. I don't want to steal the thunder of my program directors. We have two terrific program directors, one in McAllen, one here in Harlingen, and they're going to be given a very detailed outline a little bit later on about our respective residency training programs, DHR and Valley Baptist. I will be jumping back online to support their message. Mostly, I wanted to say hello. I wanted to say welcome. I'm thrilled that you guys are here today, and we're looking forward to engaging a lot of you to help us develop the unique mission of our Department of Surgery here in RGV. Welcome.
Okay, thank you, Dr. Albo. Appreciate that very much. And we also have with us Dr. Tony Obgyn, who is the chair of the Department of Obstetrics and Gynecology. Dr. Obgyn, would you like to say a few words?
Yeah, thanks, Dan. Again, I'll echo Dr. Albo's welcome. It's good to see all of you, or at least see your names on the screen. I think I don't see any names that aren't familiar to me, so it's good to see you again. Sorry we can't be in person with all that's going on with COVID. Yeah, and I also, we are in our, 6th year of the residency program now with our new residents on board. We've graduated 3 classes of residents with great success. A number of them have stayed in our local community, and others have, gone on to other things around the country. And, the program continues to grow. We've gone from 4 residents per year to 5 residents per year. I also am not going to steal Dr. Salcedo's thunder. She's going to give you a bit of an outline of our program. We've already had several events within the department, so I think that most of you most of the students in your class that have been interested in OB have heard a lot about us and touch base, and I know you all rotated, at least all of the current 4th years have rotated through our service as part of the 3rd year clerkship, so I know you're all pretty familiar with the program. But some of the things that you might not see as a student, Dr. Salcedo will touch on. And one thing I would say is that we are all very available at any time, either by email or phone. Make an appointment to talk in person if you have questions about the specialty or our program, specifically. We're always happy to meet and to talk and tell you about our great field that I've been doing for a very long time and still enjoy. I'm covering labor and delivery right now, so hopefully I won't get called away during this session, but we'll see. So again, welcome and thanks for being here.
Okay, thank you. And I believe, do we have Dr. Escamilla, I believe is away on vacation right now. Is Dr. Dobbs here yet? Not yet, okay. All right, well, we're going to go ahead and start. We're going to give about 20 minutes or so for each program here. We want to aim to wrap up at around 8 o'clock this evening. And so for each of the program directors or residents who are representing each program, we'll let you get started. When you get to about 5 minutes of the end of your allotted time, I will give you a high sign like that, just to give you a little bit of a heads up. We want to leave time, of course, for questions from our students. So please consider that. So first up is our Ob Gyn residency, and Dr. Jennifer Salcedo is here with us. She is the program director for the Ob Gyn residency at Doctors Hospital Renaissance. So welcome, Dr. Salcedo.
Thank you very much. And I'm just trying to pull up our slides here. Are you able to see the slides? Excellent. I see Dr. Obgyn nodding. So thank you. Just a brief introduction to OBGYN and our program. You've virtually and possibly in person met Dr. Obgyn, who just spoke. Our assistant program director, Dr. Serapio, is unable to make it tonight. And our administrative chief resident, Dr. Yum Dang, is currently in a hysterectomy. So that is what we love about OBGYN. So a little bit about OB. As you who have rotated with us may have learned that, we of course think we're biased, but think it's the best specialty because it offers a combination of having both long-term continuity with patients as well as, potentially specialized training or definitely operative exposure. We have the opportunity and the privilege to support and advocate for primarily women and their families over the entire course of their lifespan. We are able to interface regularly with a lot of both very challenging, but also very rewarding social and personal family issues that have to deal with, fertility and birth and family planning and sexuality and lots of very complex and engaging topics. There are also, continued advancements in our field surgically, technologically, and through, various forms of genetic testing and other techniques that keep us on our toes and have a lot of learning to offer. And our specialty is an opportunity to care for underserved patients, both domestically and globally. And, oftentimes we work in a fairly happy work environment where people are building their families and, really are able to take part in those moments. So these are some of our residents in some of their happy moments. Our program specifically here at UTRGV really aims to create leaders and change makers to take care of border and immigrant patients, as well as other vulnerable and underserved populations. So you can see this is a list of the values of our program that our residents came up with at a previous strategic planning meeting. So our program is very, very centered on that mission orientation. One of the things that students don't see necessarily when they rotate with us during third year is our weekly resident education time. So our residents all have a half day of education, and that's distributed through a fairly wide range of learning opportunities. And those are in addition to our weekly perioperative and new high-risk obstetric conferences that take place outside of those half days as well. Most recently, we have transitioned a little bit into a master adaptive learner approach, which means that our didactics are even more, learner-centered and interactive and case-based in order to facilitate the best learning of our residents. Some of the other unique aspects of our program specifically is that, our program's, newness and mission orientation allows us to really tailor rotations around resident learning as opposed to, the kind of traditional way that the resident workforce was distributed in more established programs. So one of the unique features is that we have a PGY4 clinic chief rotation that's continuous for 3 months that really allows our chief residents to have ownership of the, the management and the leadership of our resident clinic, as well as the resident led surgical services and other patient care that we offer. We also have 3 months of selectives during the PGY 4-year, which our faculty and our program leadership work with residents to individually tailor to their learning goals. That's pretty unique among programs in the country. We have a mini elective or selective during 3rd year for our residents to kind of dip their toes in the water of what they might like to pursue more during 4th year, as well as a dedicated research rotation and a number of rotations that have evolved somewhat since our program started that really focus on our specific identified learning needs. So things in ultrasound and genetics, intern rotation focusing on communication skills, as well as critical care and outpatient primary care with our family medicine colleagues. Our residents have been very successful in having their scholarly activities and projects accepted for presentation at national conferences as well as regional conferences, and also having their work accepted for publication. So this is one of our recent graduates, Dr. Vega, who presented at the Society of Family Planning annual meeting and is a first author on a publication in contraception that we're very proud of. Our department is very involved in the community. This is the Unimobile that I know many have probably been out on, and goes out regularly to provide women's health services. So our residents go and participate in those services. And we're excited that we now have our second Bold Track resident, which is a separately matched residency track we have that focuses specifically on training future leaders for border and other underserved populations. So that has a different rotation structure and some additional learning objectives to our primary program. We're very excited to have very meaningful involvement from the community physicians, primarily at Doctors Hospital, but also at some other locations. This really allows our residents exposure to a wide variety of procedural styles and management styles, and really allows a robust case volume in obstetrics and gynecology. And our residents, these are some pre-COVID pictures, so don't worry, that's why they're not masked, but our residents have their 5th Fridays and strategic planning retreats and other opportunities to focus on their team building and their wellness. And those activities are led and organized by our administrative chief resident with other senior resident colleagues. So thank you for your time in hearing about our program, and we're happy to answer any questions that you might have.
Thank you, Dr. Salcedo. Very, very well presented, very interesting. The variety of opportunities you offer residents for really deep learning. I think we're not such a large group that we can just let the students go ahead and ask questions directly without going into the chat box. So let me just ask one just to get started, kind of a basic question. I'll ask on behalf of maybe some students. In general, I suppose, or maybe for this year specifically, how competitive are residency programs in obstetrics and gynecology? And the secondary question to that is, you know, for a student, 4th year student thinking today about applying to Ob Gyn, who is doing, you know, reasonably well in school, how many programs should that student apply for?
Let Dr. Ogburn maybe provide a national perspective on that, and then I can touch on what our program specifically is looking for.
Yeah, so that's a bit of a challenging question. The average number of programs that were applied to last year in our specialty was about 70, which is way too many, in my opinion. The AAMC data would indicate that, you know, a solid student with sort of, you know, reasonable board scores and class rank and letters and things should do well applying, you know, to 30 or 40. But I understand the pressures, and it's continued to go up year after year. We had 5 people from Utrgv Match into OBGYN last year, all at very, you know, reasonable programs, and they were, you know, I would say average students or better. OBGYN in general is sort of on par with, it's not a highly competitive, but I would say it's in sort of at the middle of the competitiveness And, you know, I think the people that find a challenge are those that have what would be considered a significant red flag for program directors. For instance, if they had to remediate a year, if they had a failure on a step, that becomes a challenge, but not impossible. And if that somebody is in those positions, we have had students both recently and over the last 5 to 10 years that have had those kind of red flags that are able to match, but you really need to have other aspects of your portfolio that would offset that significantly. But I would say that, you know, most average or better students should have a very reasonable opportunity to become an OBGYN. I think that answers the question. You know, as a specialty, one thing that we didn't talk about, we are doing all virtual interviews this year, which I know that's been recommended, and there's some specialties that are still considering what to do, but OBGYN as a specialty has decided that will be all virtual, and are also really trying to, we've made some alterations in the process to try to make it a little less stressful for folks in terms of the whole interview and match process. So happy to talk to that if people have specific questions.
Okay, thank you.
Jennifer, if you want to talk about our program a little bit, about how you guys, I would say that the whole specialty is really encouraging a holistic review, and not just basing things on a board score or class rank or something. And Dr. Salcedo and Dr. Serapio have done a tremendous job of incorporating that approach into our process. I'll let her talk about that.
Yeah, as you know, Dr. Ogburn mentioned, of course, like any other specialty, we want to see that applicants have a certain amount of academic robustness to their application, so that we can be reassured that they can handle the challenges of residency. But once that hurdle is passed, we're in our program really looking for residents who have a demonstrated commitment to serving underserved populations, and look toward some depth of either leadership experience or involvement, hopefully in that respect in serving those populations, but in other activities as well, far more than having 100 things are listed on the CV. We're much more interested in depth of involvement and meaningfulness of involvement. And we have participated in a pilot program that we'll be doing again this year that includes some situational judgment and mission alignment testing that a couple other OB programs in the country have also participated in. And we hope that that will allow us to get a more well-rounded picture of our applicants outside of what we can get in the traditional application process.
Okay, thank you. Any questions from any of our students? How many first-year slots do you have, Dr. Salcedo?
We have 4 in our standard track and 1 spot in our separately matched fold track, so 5 total for the year. And the applications are submitted separately for those 2 tracks.
Okay.
All right, it must have been a good presentation. All the questions
very
got answered.
comprehensive. Yes. Any final chance here? Questions, students?
I do have a personal question.
Yes, go ahead, Lord.
So one of the things mentioned during the presentation was the fact that we're looking for applicant that have like the same goals with the program, for lack of better terms. So the fact that we only have a page with our personal statement and it has to be tailored a certain way. So how do you tell as a program director that the student match what you're actually looking for? Thanks.
Sure. I mean, I think that's always a challenge in this process, but we do look at the personal statement. One of the things that can also shine through is, when letters of recommendation know the applicant well and can speak to, involvements or commitments the applicant has had with regard to, service specifically related to, underserved populations or similar involvement. Sometimes that can really speak to that in a more personal fashion than shows up on the CV. We also look, at some of the entries that are made and how they're described with regard to, activities and involvements that the applicant has had, including, involvements that may not seem traditionally applicable. We look very favorably on applicants who have had, work experience in a variety of different areas. So we can see some of that from the CV. And then, when applicants are invited to interview, I think we're able to get a little bit better of a glimpse into, what their professional goals are and priorities are when we're able to see them either in person or virtually, as will happen again this year. So I don't think it's a perfect process, but I think there's a number of ways we can help build a picture of the applicant. And there are a ton of really excellent OBGYN training programs, and there are a ton of really excellent applicants. And really the process is about trying to find, a good match between programs and applicants. So I think we're all doing the best we can to help build that picture of the applicants while they're concurrently trying to build a picture of our program.
Yeah. Thanks, Jennifer. That I would echo everything you said, but Lord, I would also add that I really think it's the picture that you paint of yourself, both in your application, that includes, as Dr. Salcedo said, your letters, your extracurricular activities, your work experience, and then also your interview. I mean, and I think at the interview, that gives you the opportunity, most people get asked a question along, what are you looking for in a program? And that's your opportunity. There's some pretty standard answers. I want to be a well-trained OBGYN, but it also gives you the opportunity to express if you do have desires about, something that you want to see in a residency program. And, just a sort of a simple example, if somebody, says, well, I'm really I want to be a researcher and I'm, really interested in research and I want to go to a place that's really strong in research. One, that's probably not what we're doing here. But also, if we look at their application and their letters and they've never done any research or doesn't have any experience in that area, that would be kind of like, I wonder how they are so confident about that's where they want to be. So, but for most people looking at an application, you can read it and get a sense of what their interests are just by what they've already done and what they've accomplished and the view that other people have of them. So.
Thank you. Good questions. Any other questions for Dr. Ogburn or Dr. Salcedo? Okay. Thank you, Dr. Ogburn, Dr. Salcedo. Thank you both very much for being here with us this evening. Students, I'm sure that if you have questions you think of later on, you can approach them with those questions, and I'm sure they'll be glad to respond to you. Okay, thank you all very much. We're going to move on to our next program, and I understand we're going to flip the order of the program here a little bit. Melody, I think we're still on for that?
Yes.
Yes, okay. And so I'd like to welcome Dr. Henry Reinhart from the General Surgery Program at Valley Baptist. This must be one of our newest residencies, right, Dr. Reinhart?
I believe so. I believe I am the newest, or we are the newest, excuse me.
Okay. So
thanks.
welcome, glad to have you here.
Thank you for having us. This is a great venue. All right, can you all see my screen okay?
Yes.
Yeah, okay, good. All right, so I know there's one potential surgeon in the crowd that I saw. So as everyone knows, this is a brand new program centered out of Valley Baptist Medical Center in Harlingen, Texas. I believe the new chairman, Dr. Albo, is on also, along with the program coordinator, Sonia Padilla. So if anybody has any questions, if I miss anything, y'all please feel free to chime in. So we were accredited in January of this year. Since the program was so new, along with the department, we were approved for 2 residents per year to start with. Our first site visit will be in 2023, so we could apply to have more residents at that point, which we most likely will. I think we can accommodate very easily 4 residents per year, and I think there's going to be adequate training to have possibly even more than that in the future. So our projected start date is in July of the coming year. And like I said, this is our main training hospital will be Valley Baptist in Harlingen, Texas. Since I can't really take anybody on a tour, and nobody's really seen the actual department, I just wanted to put up a floor map to give everyone an idea. So that whole 5th floor of one of the towers at Valley Baptist is dedicated to the surgery department. And the areas in yellow will be dedicated to the surgery residency. The outlying offices will be administrative staff and of course faculty. But if you look at the large area here in the middle, I just want to point out these areas because these are what I'm really excited about. Essentially, I got the ability to design the surgery residency that I always wanted as a surgery resident. So I've taken a lot of pride and I've built this whole program around that, making an excellent training program. But here and here, you'll see these 2 big areas are actually going to be a large simulation lab. We're going to have a state-of-the-art simulation center that's probably going to be close to $1 million when all is said and done, with all of the, all the newest equipment available. This is really big in surgical training, just like it was in flight training several years ago, and now that's rampant in the industry. And I feel like surgery is probably going to be the same way, just because we have so much to learn, and this facilitates that learning in such a quicker time period. But this will be the simulation lab. Over here, we have a large resident work area for the residents and a large lounge. We'll have call rooms in this area, and we'll also have call rooms in the hospital, and along with showers and everything. So it's a very impressive space. I just wanted to point that out. I don't think I missed anything. And I'm working on incorporating an actual workout area in there specifically, but the hospital itself actually has a gym built in. Right now we have 2 off-site rotations. One will be Driscoll's Children's Hospital in Corpus Christi for the dedicated pediatric surgery rotation, but we're working on some other options. So potentially residents would not have to go to Corpus Christi for a month. And the other is for a dedicated transplant rotation, which would be at the Methodist in San Antonio, where they have a good volume of liver transplants in addition to kidneys. So it'd be a very good, well-rounded experience. I actually did that when I was a resident at that particular training site. So you all know I'm the program director. The chair is Dr. Albo, who joined us from Georgia. And it's a great privilege to have him here just due to his experience with building programs. And he realizes personally how important a residency is, a surgery residency, because it is the cornerstone for which to build so much. And he's very excited about the program, and he's very, very supportive. So I think we have the building blocks to build something truly incredible. And then of course, Sonia is there. If you guys have any questions, if you want to reach out, you can reach out to any of us, but include Sonia because she will be the go-to person to talk to. So currently we have 7 core faculty and 18 clinical faculty. The 7 core faculty are general surgeons at the hospital. That's projected to grow substantially as we build the program. So we'll be adding more general surgeons. Currently, we have fellowship trained specialists in trauma, in burns, endocrine surgery, hepatopancreatobiliary surgery. surgical oncology, and advanced surgical endoscopy, in addition to several general surgeons. So right now we already have a very well-rounded experience, and this is going to grow as we add more surgeons. So as you can imagine, the volume is quite large. Our goals, we want first to produce competent physicians, will be leaders. We don't want to create general surgeons, we want to create leaders. Secondly, we want residents to become lifelong learners. And I feel like, having worked at many institutions, that's what differentiates good surgeons from great surgeons. We do want to emphasize the importance of scientific discovery, and that's worked into our curriculum, and we give you time for that. So it's not like you're going home and having to work after hours on projects. We actually worked that into the residency program. And then we want our students, or our residents, to be technically competent and absolutely pass the board exam. I do not want to graduate residents who do not take the board exam or cannot pass it. These are our objectives. I won't read them to you. This will be available on the website, so you can read about them. But if you have any questions about them specifically, please reach out to us. And then these are not only do the residents have objectives, but of course the faculty have objectives, because we essentially want to make the faculty, we want to improve the faculty. And I feel like one of the reasons I personally wanted to go into academics, because working with residents has made me a better surgeon, and we want to apply that to all the faculty. So to give you an idea of our rotation schedule, the way it's set up, since we only have 2 residents to start with, they kind of get their pick of the litter. They get to choose kind of everything they want to do. There's going to be multiple surgeons operating at given times that they can work with, but we essentially broke it into an ICU and trauma rotation, and then a surgery rotation. The surgery rotation will include all the various specialties along with some vascular surgery. The PGY2 and PGY4 years were kind of set up to do more specialized work and some electives. So there you'll be working in your endoscopy rotations. You'll also have a month dedicated to research or QI, since you now have to graduate. You have to have some sort of research or QI in order to graduate. We actually incorporate it into our weekly didactics, but we also give you a month to work on projects specifically. That way, by the end of your 4th or 5th year, you've seen this project to fruition. You're able to write it up, get some publications. And we have a robust research coordinator to help with all of this. The 4th year is really exciting because I designed it with an elective month. You get 2 elective months that you can choose to use in whatever you like, wherever you like. If there's a program you really want to go to, you're welcome to go do an away rotation with them. If you wanted to go to MD Anderson, or if you wanted to work with a surgeon here in the Valley, we could also set that up. But then you'll also do your peds rotations, your cardiothoracic vascular surgery rotations, plastics rotations, and then some head and neck, because some general surgeons are still expected to take care of things like parotids. And then some, you'll see lymph nodes of the neck that you'll get as a general surgeon that you have to be able to address. And then of course the transplant rotation that I already mentioned. And then the 4th and 5th year will be the chiefs of the rotations. The weekly didactics will follow a rotating schedule. The first Friday, every morning we'll have morning report, not just on the Fridays, but every day of the week we'll have a morning report at 7 a.m. to go over all admissions, all imaging together as a group with the faculty involved. So all questions are answered and everybody's on the same page. So the first Friday we'll have grand rounds. Sometimes we'll be invited grand rounds. So we'll bring lecturers from other programs to come talk. Then we'll have surgery M&M, and I worked in a research and QI update so we can keep everybody on track with their projects. And then we'll get into our traditional didactics that y'all are aware of, book didactics, based around the SCORE system through the College of Surgeons. And then here we have sim and research. So you'll actually have dedicated time in the simulation center to work on the simulators so that you can work on your times, your techniques. And then other days you'll rotate so you'll have time to work on research projects you have going. The first Friday we'll have a tumor board, and then the second Friday we start doing a trauma M&M. The quiz and didactics are the same. Then we have small group discussions where we work through a scenario as a small group, and you can, 2 or 3 residents will be with each attending to work through these. And then again, you get your SIMA research time, and then we included the curriculum that's provided by the university to talk on quality improvement, research, wellness, opioids, all these little topics that we have to include. The third Friday will be all of this same stuff that we've rotated on, except we included selected readings in general surgery. That's kind of a neat resource in that they choose the most important literature that's come out recently, and they publish that in one single, essentially a magazine. So we can go through the selected readings for that quarter of all the important literature that's come out to keep everybody up to date. And then the fourth Friday, we add mock orals into the mix so that every month we're working on our oral exam skills. And then a fifth Friday, which happens usually about 4 or 5 times a year, we're incorporating resident wellness. Sometimes we'll have retreats, events for the residents to participate in, and then a journal club. Right now it's scheduled for every other month, but it may become monthly. The elective rotations I mentioned, you can do them offsite at a different institution if you have interest. And I mentioned the simulation lab here. You can see the LAP mentor and the GI mentor. These are 2 very expensive but top of the line simulators, so that we can get residents ready for procedures for their fundamentals of endoscopic surgery exam, their fundamentals of laparoscopic exam, and also will become eventually a testing center for FES and FLS. So all the OB residents in the Valley won't have to go elsewhere to get tested. Everybody can come to our testing center, including the other surgery residency at DHR. And then we also have a robotic simulator. We have an SI robot at Valley Baptist, and I'm going to start working with them, hopefully to get a second robot, so we have a dedicated surgery robot. So other reasons, why should you think about coming here? What makes us different than other programs? First, there's no fellows whatsoever. So the residents get all of the volume. I mentioned the operative volume. There's going to be more than enough surgeons to go around. So I predict there will be many uncovered cases because there's going to be such a large volume available. The diversity in the Valley is just out of this world. The cases that you see come up from Mexico, you'll see advanced cases that you won't see anywhere. The pathologies will be much more advanced that you would see at other places. I've done in my tenure as an endocrine surgeon, probably 35, 40 adrenal surgeries, which is relatively high volume. Today, I saw my first 10-centimeter tumor. I've never seen anything like that in an adrenal gland. So the pathology here is just out of this world. Residents will also get a book fund. We have mid-level support for all services. So this is not a service-oriented residency. I trained at a service-oriented residency. I've worked with several service-oriented residencies, and I did not want that to be a big burden on the residents. So we will have mid-level support for all the services. I mentioned the dedicated QI and research time so that this isn't eating into a resident's off time. And then another thing that I'm really excited about is the CORS system. This is one of my biggest pet peeves with residency was building a patient list in the morning for everybody, going over the labs. And I always felt that was just a waste of time. Well, this is a system that's built to work with Cerner, the EMR that we use, and it'll create a whole list for everybody. It'll be available on your phones. The other services at the hospital can use this so they can see what we're expecting as surgeons if we're consultants, and it'll track what we need. And everybody can visualize this in the hospital. It will make the checkout process much more smooth. You won't have to spend as much time doing like record tracking, laboratory studies. Everything will be available to everybody at once. And the most important thing is this is a brand new program. I know we're going to make changes relatively often as we grow to better the program. And the thing that I want to emphasize is that we're very willing to do that. This program is, I've worked at very old programs, and the status quo was kind of omnipresent. We never changed anything because that's the way we had always done things. Well, I don't want to be a program like that, and I want to make this one of the best training institutions I possibly can. So, at least that's what I think some of the benefits of this particular residency are.
Dr. Reinhart, excuse me,
yes,
can you just go back again?
Yes, sir.
Mid-level support to offload service burden. Can you explain that a little more?
So,
yes.
Right. So essentially, there's going to be a dedicated mid-level on each of the services.
That's a PA or a nurse practitioner?
Yes, sir. That's exactly what it is. A nurse practitioner or a PA. So any of the service, say a discharge, like a discharge, could be taken care of by the mid-level so that the resident can participate in the OR or go to clinic. They're not burdened with the excessive service load. If a resident calls in sick, we have a mid-level that can help out with the service. The other residents aren't left to cover the empty spot. So I'm really proud of that. I know a lot of big programs have a lot of mid-level support, but I built this program specifically so that there was support. Residents did not feel that they had to be available all the time, that there's people there if, for whatever reason, if something should occur. The application is the same as most surgery programs. We will conduct our interviews from October to January. Of course, they're by invitation only, and then we'll be doing it virtually, just like most of the other programs. Any questions?
Dr. Reinhart, the AAMC announced that some programs in surgery are going to ask students to complete a supplemental application. Are you thinking about doing that for your program?
We are evaluating that right now as we speak. I think that might be very useful in the future, especially, right now it's kind of a mixed blessing, but most programs use step scores to kind of get your foot in the door and screen residents. And, whether that's good or bad, I can't say. But I think once the scores go to pass fail, I think that supplemental application will actually be very beneficial. So we're looking into it right now as we speak. There was an online forum about it recently, a few days ago. So most likely we will participate.
Thank you.
Dr. Albo, do you have anything you'd like to add?
First of all, thank you, Henry. This is a terrific presentation. Henry has done a tremendous amount of work getting this up to speed. I think this is the intersection between really high-end surgical services with a huge emphasis on some of the most sophisticated minimally invasive surgical platforms. So we have a multitude of faculty that are really experts on advanced laparoscopy of different types and advanced robotic surgery. The SIM Center is going to be built literally in the middle of, we have dedicated space in the hospital, right on the 5th floor. The entire 5th floor belongs to surgery. In your living quarters, your socializing environments, and your SIM Center are all going to be in this exact same area. And so the accessibility to it is 24/7, which is another important resource. We have completed the purchase of an Xi robot, and we have an autonomous Xi simulator slotted to come now in November as well, which is going to complete the surgical simulation environment. The simulators themselves are going to be supported by a very robust curriculum. So it's not just a bunch of toys sitting there, but actually instruments that Think about how you train in modern aviation training, a marine aviator pilot, and you get the idea. They do almost half of the training on advanced simulators, full immersion simulation concepts. We actually have developed and helped develop a lot of the educational modules for these simulators and the entire curriculum that supports them for surgical training in our previous stops. And so there's a lot of competencies involved into that are going to greatly accelerate the trainees' learning curve and not only make it faster, but make it actually more sophisticated and safer to transfer into the environment of real care in the ORs. This is a program that is built for innovation in surgical education. And we're going to build the entire Department of Surgery around it. It's the main reason why I chose to come to the Valley. Dr. Reinhart has my full and undivided support. And we have a large foundational grant that supports this program. I think is worth mentioning. This is the Valley Baptist Foundation grant that we actually operationally control in terms of funds transfer, meaning this entire program is supported by a $15 million grant that makes it very robust in terms of investment for now and for the future. This is a core mission of the entire medical school, and certainly it is a core mission of the Department of Surgery. We're really blessed to have Dr. Reinhart and an advanced team of surgical educators behind that. So that's all really I have to say. I think, Henry, you did a really phenomenal job presenting our program to the world. Thank you.
Thank you both. You know, Dr. Reinhart, when you talked about the kind of the vast amount and variety of pathology, you know, that speaks to the fact, of course, that this is a hugely underserved area. Lots of lumps and bumps that went perhaps ignored or about which people couldn't do much. Finally, you know, come forward, and especially when a program such as yours makes the opportunity for care available. Yes, there's an awful lot of pathology that needs attention here in the Valley, in all fields, and certainly surgery no less. So it makes for a very challenging experience, I'm sure, for both faculty and residents. But also a tremendous opportunity to serve a great unmet need.
Couldn't agree more.
Perhaps, you know, if I can piggyback on that, we were talking with Dr. Vela today, the chair of family medicine, and we're going to be building together an Institute for Health Services Research at Utrgv. My intent is to actually hook up all of our residents into a fairly advanced health services research and policy research and other types of population health sciences research as they go through residency, because we do serve one of the largest underserved, particularly Hispanic patient populations in the country. And there is an enormous opportunity for that type of research to be very, very impactful. It also happens to be a terrific career developer for young careers in academic surgery. We are not only going to have access to funds for books. I'm actually the editor of one of the textbooks in operative techniques in surgery, and we're going to give you guys one copy every year. From that, we're about to come up with the newest edition of that this year. This is really a lot of tiers to this program in education, service, and in research that will allow you to successfully apply for some of the highest level fellowships across the country. We have a very large network of academic connections. We have several faculty that are very, very active in academic surgery. I'm the past president of the Association for Academic Surgery, and I can tell you that we can get you connected with some really high power fellowship training programs for life after surgery if this is a career pathway that you are interested in.
Thank you. Yeah, Valley Baptist, you know, as evidenced through the Valley Baptist Foundation's commitment to the program, and the hospital itself has, you know, has a history, I think, of, you know, once committed to a project, you know, they're in it for the long term. They've always been, you know, leaders here in the Valley in reaching out to the community and offering educational opportunity. So I think the program is well situated to take off and grow very quickly. So we wish you all the best as you step forward.
Appreciate
New
it.
class starting in July 2022.
Yes, sir.
So for students, this is a chance to be a pioneer.
Hi,
Yeah.
I had a question, a real quick question. My name's Salcedo, third-year medical student, and I just wanted to ask. So, as you know, step one is converting to pass-fail this upcoming year, and specifically for the class of 2023, we're going to have a mix between people pass-fail and having a 3-digit score. How are you guys going to go about picking students for interviews and ultimately a spot for the residency there? And this applies basically to all the specialties.
Sure. That's a very good question. I actually was a part of some studies and actually had published some literature where we looked at scores, and our hypothesis was that scores might not represent the best suited candidate for a residency, and we actually opened up the number of candidates we would take, not based on scores, but based on other aspects, letters of recommendation, their rotation scores, their extracurricular activities, to see if we could find a better algorithm to choose residents than scores. And I've got some publications from it. It was really, really interesting stuff. But in that same vein, I think we're going to have to expand outside of scores, and we would look at, how you did in your clinical rotations, along with your first 2 years, your letters of recommendation, and then kind of build on that. Of course, Texas, we'll look heavily at Texas residents, especially, people from this area. But truthfully, I think this is an exciting time for surgery because, this is going to open the door for people that might not necessarily have gone this route in the past.
This is a very interesting time in surgical education. This is a very hot topic, actually, of interest right now across the country. Program directors sometimes are struggling with this. I embrace it. I am actually very supportive of what is happening now. Because if you want to think about the program, the type of person that we want to attract into our program, it's really the person that we want to embrace. Much more holistic approach to our recruitment of not just residents, but faculty and everybody into the department. The STEPS course is just one tiny component of you. I'm much more interested in the rest of you. What is your community involvement? What is your sense of mission in life? How does that personal statement read, and what does it tell me about you? The people that you have worked with, what do they have to say about you? The people that know you better. How did you do in your surgery rotations? As a matter of fact, I'm more interested sometimes in your shelf scores than I'm on your STEP scores, to be honest with you. This is much more content specific to our world. But more importantly, what does the entirety of your application tell me about you as a candidate, as a person, and as a human being? Because once you join us, you become part of a family. We pride ourselves on being an extended surgical family. And we want to bring the people in that we will gladly call our brothers or our children, or our sisters and our children. And so this is the kind of person that we're looking for. And to be frank with you, I've seen some fairly well maladjusted individuals with very high scores over the course of my career, and incredible people that happen to not have scored for a variety of different life reasons as high as others. And so I don't put a ton of emphasis on the STEP course to start with, and now with the pass-fail even less so. But we look at the totality of the application is the best we can answer that.
Great, thank you.
Thank you very much. Very interesting, I think very informative. And Osviel, yes, I think, that question you posed and the answer you heard, we'll ask that to other programs as they come through here, but I think you'll hear pretty much the same answer, that STEP scores have been, well, even before they go pass-fail. In fact, that's probably the reason they're going pass-fail, to try to decrease the charge and the anxiety that's hung around step one, especially among students. And get students to focus not so much on the tests, but developing themselves throughout the entire curriculum, and of course programs interested in holistic evaluation of each applicant. So big challenge all around. Thank you, Dr. Reinhart. Dr. Albo, thank you very much for being here with us this evening.
I had a question.
Yes.
I'm Valentine Leah. I'm a second-year medical student at Utrgv. I just wanted to further inquire about something that Dr. Albo had said. I know you're speaking on that you are planning on making a facility incorporating research on public health with the family medicine program. But I was wondering, do you think in the near future, y'all would have any opportunities for the medical students to interact with the program as well, just to further explore?
Absolutely, sir. Absolutely. Reach out to us. We have several avenues of opportunity for that. The idea, what I was talking about earlier, is to build a comprehensive full-fledged institute, School of Medicine wide. But yes, we do have opportunities for very impactful research, I think, to be a part of and to begin to build your portfolio.
Okay, thank you.
Okay, thanks for that question. I'd like to go ahead and move on now. We have, I think, folks here from the general surgery residency at DHR with us. And thank you for being here. I heard you've had a busy evening. DHR, as you all know, has been a major partner with the School of Medicine in Hidalgo County. And in relatively short period of time have developed several residency programs. You heard earlier about the Ob Gyn program, and they also have a surgical residency program, which is now, well, Dr. Nurishirazi, you'll tell us how old the program is, but welcome. You are, Dr. Nurishirazi, one of the residents, as I understand?
Yes. Hi, I'm here with Jesus Garcia. He's also on the call as well. We're both residents, fifth years.
Very good. Welcome. So
Thank you.
We'll give you the floor to take about 20, 25 minutes to describe your program and your experience in the program and answer some questions from our students.
Okay, awesome. I'll share my screen. Okay. Are you able to see my screen?
Yes.
Okay, I hope everything's okay. So I just wanted to take some time with Dr. Jesus Garcia to talk about our general surgery residency program here at DHR. So we just graduated 2 of our initial classes. So we're about 6 years old, and I'm just going to talk about our program real quick. So we have a total of 24 residents. It's 4 per year and 4 prelim years for intern year. So we have 24 total. And I guess whenever we talk about residencies, everybody wants to know what's our biggest strength. And for us, I would say our caseload is pretty great. And this is my case log. It's not even completely up to date, but coming into 4th year, and I would say about midway through 3rd year, I was already done with all of my cases that I would need to graduate. All I need out of 200 cases is a chief that you can't get until your 5th year anyway. And so there's definitely no struggle for cases here, which is pretty amazing. And then even now with 24 residents, there are cases that go uncovered because we just have so many cases here. We have many subspecialties that you can rotate on, and you will rotate on. Those include endocrine therapy, hepatobiliary, transplant, cardiothoracic, breast surgery, colorectal surgery, vascular surgery, trauma critical care, pediatrics, plastics, and bariatrics. And we do have a subspecialist in all of these. And then we, of course, have our general surgery rotations, and a lot of the rotations also incorporate general surgery along with subspecialties, so you never really lose out on the general surgery throughout the 5 years. And then we recently are about to be level 1 trauma, we think. We've had a lot of exciting cases. Sorry, I was a little late today. The reason was because we just had, I think 7 traumas coming into the trauma bay at the same time. So we're all the residents rushed over there and we were helping there. Some of the pictures, there's one of Dr. Skubich, who's our trauma director, and he's been very, very involved in our education, and he's one of our biggest advocates when it comes to resident education. So we're very lucky to have him. We've had very cool cases here, and even just this weekend, we just had a trauma XLAP for splenectomy. So we do see really cool cases. And then, sorry if this is like graphic, we have some other cases. I know we talked about it a little bit before. You guys were mentioning how we do have some very delayed diagnoses because things were, I guess, left unattended for a long time. So we have masses that have grown out of proportion, fungating breast masses. We also have just large abdominal masses that are unknown till we do the XLAP and send it to pathology. We have a large bariatrics program, so we do paniculectomies, but also we have a very robust bariatric surgery in terms of sleeves and also bypasses. We do have NICU babies here and a lot of other cool cases. So a lot of the benefits for our program, I think, we don't have any mandatory away rotations. We used to rotate in San Antonio, but we were able to fulfill everything in-house. So all our rotations are here, but you are allowed 2 months of away elective rotation. So if you want to go somewhere else for those 2 months when you pick a specialty during your 4th year, that's definitely a possibility. And I'm sure a lot of the students already know the beach and the warm weather here is great. Low cost of living, which I thought was very important as a resident. I see my friends struggling in New York and California, trying to make it through with just resident salary, which is difficult. And we don't have any competition with the fellows. So we only have residents right now, no surgical fellows. So all the cases go to residents. And we don't have to compete with fellows for cases. And in a lot of places, if you have fellows, the cases are, first dibs by the fellows, and then the residents get whatever is not taken by the fellow. So it's nice. And I like that we're a hybrid program. So I think we have the best of both worlds. We have the academic surgeons, which is really nice to have, really up to date on all the recent studies, all the recent data. But then having the community surgeons, if you're interested in private practice too, then you see the functionality of what a private practice is like. So it's nice to see both sides. We're pretty robust in our program in terms of academics as well. We do have weekly gram rounds. M&Ms are held every week. This is all on Mondays. We have a dedicated half day. So from 8 to 12, residents are completely dedicated to conference, and all the patient care is on hold and done by the timing. So we have our protected time. And then we also have both, I guess, attending-led lectures and resident-led lectures. We go through the SCORE system, the SCORE curriculum. And so everybody does that weekly. And then we also have API, so we have extra studying time and resource for ABSITE. And we also do offer mock oral exams in preparation for the oral exams. Those are for primarily PGY5s, but we've done them between PGY3 and PGY5s. We have a very nice skills lab, and the PGY1s have dedicated time to learn technical skills before they go to the OR. But I think the best thing is, even from day one, we have residents, interns going into the operating room. We do very much encourage that. It's been that way for everybody, and it's been that way for the last 6 years. So we want to continue that. And we do have journal club, and we also have ultrasound training as well. And another thing that I thought was unique, I don't know how common it is now in training programs, but when I applied, only one program was offering certification for their residents by the end of their 5 years for robot training. That is very much encouraged here. And so a lot of the attendings do robotic cases. So you're required to do a certain number on the bedside assist, certain number on the console. And we do a training session in Houston. And after you complete all that and the online modules, you're considered certified, which is great. And like to say, we're very family friendly. We have a lot of residents, not even pictured here, who have families. And we even had a couple that got married last year within the residency. So, and a lot of people are animal friendly as well. And I think overall, we're just a very happy group, and we get together a lot on our time off as residents. And so I think it's a really great place to be. I've really enjoyed my last 5 years. And if anybody has any questions, Jesus and I are here to answer them.
Thank you very much.
Thank you.
Let me ask you the same question I asked Dr. Reinhart about whether in reviewing applicants for your next class, will you be using the supplemental ERIS application that some programs apparently are going to use?
That's a good question. I'm not
Yes.
really sure. I haven't spoken
This is
to-
Roberta. I'll answer that question.
Roberta, you would know.
So yes, we will be. I'm the program coordinator for general surgery. So yes, we will be using that system.
Okay. And that's new this year. Some programs is surgery, internal medicine, and dermatology, as I understand it. And about half the programs in surgery and medicine and about 3/4 of the programs in dermatology will be utilizing the supplemental application. Right. And so you will be doing that. Okay. One of the students earlier asked a question related to, the importance of step 1 scores and then what's going to happen starting next year, for our first or second year students who may be aiming for careers in surgery, when step 1 converts from numeric to pass-fail grading. How will you all decide, who to interview, or how will you factor that into your evaluation of students?
So we're going to feed off of what Dr. Reinhart and Dr. Albo said, is that we look at the resident as a whole. And so when we're looking into the ERAS application, we do look at their scores, but that's not the determination of our selection. We do look at the letter of recommendations. We look at their academics from medical school. And then we just look at the person as a whole so that we can get a decision of who we want to select.
Okay, very good. Thank you. Other questions, students, comments? How competitive would you say general surgery programs are? And for a student who's done, reasonably well in school and wants to apply for surgical residency, how many programs should that student apply to?
That's a great question. Kevin, are you still on?
Yes, I am.
We just had this exact conversation. In your opinion, after we discussed everything, what do you think the optimal number is based on the numbers we looked at?
Yeah, like Dr. Reinhart said, we spent a pretty good amount of time talking about this. We were looking through a lot of the most recent match statistics, and it was looking at around 40 to 45 programs to apply to was the ideal amount.
And how many
set
interviews?
yourself up to match. And we were looking, I think we were looking at 2019 and it was around 12 to 13 interviews. And we were kind of anticipating maybe adding 2, 3 to that to kind of reflect 2021.
Yeah, all that data was based on Charting the Match that came out in 2019. And if you did what he just mentioned, you had was it 95% chance of matching.
Yes, sir.
And that was based on average board scores, nothing stellar. But if anybody has that question, I really highly recommend looking up the Charting the Match. They publish it every about 2 years, and it really gives you specialty specific details, looking at publications, looking at scores, and several other factors to give you an idea of where you stand, how many interviews you need to go on, and how many places you need to apply to. Right now, I think medical students apply to way too many programs, and now that interviews are virtual, it's so much easier to interview that I think it's kind of clouding that data, but I still think that stands true. So I would say maybe do about 15. If you're a pretty competitive candidate, you should be good. I wouldn't really go over 20 though. I don't think there's any benefit. There's definitely a number, and it's based on how well you did during medical school. But you hit a number that once you get over this number, there's no return.
Yes.
At all.
Yeah, the AAMC has a page on their website called Apply Smart, and a graph showing that relationship between step 1 scores and the likelihood that you will match in a program, with different numbers of applications. And certainly there's a point of diminishing returns. And so the idea of having to apply to 80, 90, or 100 programs, for most students, that's entirely unnecessary and excessive.
Yeah, and expensive.
And expensive, yes. Even with virtual interviews, it's just, just way too many.
I agree.
Other questions, comments? Kevin, good to see you. How are you doing?
I'm doing well, Dr. Fish. Good to see you.
Yes, all right.
Sorry to put you on the spot, but it was just too perfect. We talked about this yesterday.
That's okay.
Very good. Okay. Final chance, students. Well, not final. You can reach these folks later if you have questions. So, all right. Thank you, Dr. Urology and Dr. Garcia. Thank you for your participation with us this evening. I'd like to go on next to the urology residency at DHR. And we have Dr. Veronica Rodriguez here. And you're a resident in the program also, Dr. Rodriguez?
Hi, good evening, everyone. Yes.
Anybody else with you from your program coordinator?
Just me right now.
Okay,
yes.
It's on you. Okay.
That's okay. Well, thank you for the invitation, first of all. I think I can start sharing my screen. Okay, so yes, thank you again for the invitation to present our newly open urology residency program. I'm Veronica. I'm originally from Venezuela and moved to the US a couple of years ago to pursue this dream of mine of becoming a urologist. Before I got to the Valley, I was able to complete 2 years of general surgery residency in preparation for my training, which is not required to be a urologist, and also did 2 years in research, minimal invasive surgery. And now I'm on my 2nd year of this residency training program, which is a 5-year total program. So this is our team. These are all my faculties. I'm proud to present them. The first one you see here is Dr. Henry Reese. He's our chairman of our program. He's a board certified urologist and he specializes in pelvic reconstructive surgery. And he's one of his kind in the Valley. He treats a very large number of patients with those pathologies. Here you see Dr. Obgyn. He's our program director, who worked pretty hard to open this residency program. Among the other faculties, he specializes in minimally invasive endo urology and does a large number of cases treating endocrine, stone cases, and also oncologic patients as well. This is Dr. Alonso, the third in the picture. David, he's a urologist board certified as a urologic oncologist. So that's one of the strengths of our program. We have different subspecialty trained faculties that provide education and training for all their, because our fellowship trained as well. So he does specializes in bladder, kidney, uterine, and penile cancer. He will do open and laparoscopic and robotic surgery as well. So we're very happy to have him here. And this is Dr. Gustavo Villegas. He's a general urologist. He does a wide variety of cases and treats different variety of patients in the spectrum of the urology. And he's one of the founders here in the Valley and he made us as a Urolift Center of Excellence, since he does a large number of those cases. A new technique I'll show you later. I have a picture of it. And he participates in those cases. This is Bianca, our program coordinator. And so far, the residency members, Octavio, he's our first year urology resident. And we, in our program, is a 5-year program. We do 6 months rotations in general surgery. So he's currently right now doing his surgery rotation the same way I did last year. And me completing the second year just started. So our residency program, we're very proud that just opened last year. One of the strengths of our program is that if you join us, you'll be able to build with us the new residency program. That's the way I like to see it. We pretty much are creating the foundations and the rules of our residency. And I think that's one of our strengths. We have a wide range of learning experiences from academic didactics and all the way to surgical skills. And as I mentioned before, for the background of my faculties, we're exposed to all those cases as well. And the same way that surgery programs, as they say before, and OBGYN and the other subspecialties and specialties that they talked today, we have a very high operative volume here in the Valley. There is no such comparison to other programs I've been before. I've been in several programs, but we do have a large number of cases, that's no doubt. During my first year, I almost completed a total number in 1 year of almost 400 cases. So you'll definitely have exposure coming here to the Valley. We don't have fellowships yet. So all the surgical cases go to the resident. I'll show you later, but our curriculum is divided in different subspecialties across the 5 years. So during my first year, I did 6 months of surgery and 6 months of general urology. So since there are no fellows, you are pretty much the first assistant to the main surgeon. And sometimes you become the first surgeon as well. I like to see us as a multidisciplinary specialty. We work with a lot of the other teams. So we work with the transplant surgery team, We work with the interventional radiology team, and we work in close contact with the ICU critical care and medicine team as well, OBGYN sometimes too. So we are consultants for them and vice versa. So I really like the dynamics of work here at DHR, where we're allowed to work as a team. I really enjoy that. One of our specialty perks is that we take care of urologic emergencies. Last year, since we recently became a level 1 trauma center, we take also isolated urologic traumas. So last year we had an isolated urologic trauma that we took to the OR one day in the ER. We take home call. So I'm on call 24 hours. I'm at home, I'm available. So every time there is an emergency, a priapism, an infected stone in a septic patient, or trauma or any of that, I'll come with my attending, and we take the patient to the operating room, or we provide care in the ER. So it's pretty cool that we also get to do that. And our facilities, we practice here at DHR Hospital. Our main operating rooms are here. We have simultaneously, there will be three or two faculties operating the same day every day. So there are multiple ORs open at the same time, available for cases for our future residents and our current residents. We also operate a day surgery, where we do most of our reconstructive cases, implants, interstims, and also joint cases with gynecology residents as well. I probably know a sacrocolpopexis and all the others. And we have our clinic, our urology clinic, which is across the street, where we see all of our patients. That's one of the things I love about urology. By being a surgical specialty, we get to have a close contact relationship with our patients in the clinic. We operate on them, we follow them for years to treat cancer, to treat men's health conditions, and female as well, or pediatric patients at neurogenic bladder who will have to be followed for a long time. So we have those characteristic things as well. So I like to think also of urology as of multiple subspecialties within the specialty. This is pretty much part of my curriculum in my 5-year program. So first year, we do a lot of general urology, meaning prostate surgery, stone surgery. We do hydronephrosis surgery, we put stents. We do bladder tumor resections as a first year. You'll get to do that. And Endo Urology, this is my current rotation. I mostly treat stones through different approaches, and I'll show you a bunch of pictures later. But we treat stones through urethral approach, through flank approaches with the nephroscope. There are many different ways to minimally invasive treat these problems. And we have pelvic reconstructive surgery. Further in second year, pediatric urology. So we have currently 3 pediatric urologists that come from San Antonio every month. One different pediatric urologist every week, and they stay here about 3 days. They operate 2 days, and they do clinic one of those days. So now we've joined with Driscoll Hospital for our pediatric group, and they're going to start building their pediatric tower, and then soon enough we'll be rotating in that hospital as well, join with DHR. So that will be coming in the coming years. And of course, we have minimal invasive surgery. We do our robotic cases. I've done robotic cases as a first year to assist, and also in the console, we also get certified through the robotic surgery program. one of the perks, Dr. Obgyn, who is our program director, is also the director of the robotic program here at DHR. So we're very blessed to being trained by them as well. And of course, all the way to transplant surgery, we work with the transplant surgery team, and we do cases of donor nephrectomies as well every month, and our oncology surgery cases too. So why urology? I think it's a perfect combination between, for me, treating oncologic patients, but at the same time, you get to treat cancer. You also get to do those complex, big reconstructive cases and follow your patients along the way, and you build a relationship with them. Like this case, one of my favorite cases from last year, this is a patient that's bedbound. He had cerebral palsy and had a history of chronic stones, and unfortunately a non-functional kidney with a stone that was occupying most of his renal collecting system. So we had to perform an open nephrectomy, but at the same time we had to get rid of stones in his uterus. So with my hand, I'm holding a scope going all the way in through his uterus, and we got to remove this before we remove the kidney from his body. So it's kind of a complex case, but we were able to do it. We also do cases of Endo Urology. There is a lot of people involved in our operating rooms. We have the surgical techs, the OR nurses, we have the OR circulators, everyone, it's like a theater, everyone, the anesthesiologist, everyone plays a role. There are multiple screens at the same time, which is pretty cool. We have the C-arm, we have fluoroscopy, where we can see live what we're doing at the same time. And then we have the screen to see when we enter with the cystoscope or the ureteroscope or the nephroscope. So I think it's a beautiful thing that happens in our operating rooms. And this is the robot. This is Dr. Obgyn doing a robotic prostatectomy. Pretty much dissecting the vas deferens from the prostate, and doing robotic surgery, and I was sitting in the console, seeing him operate and learning what he was doing. This is me practicing in the robot, pretty much. This is Dr. Alonso, one of our faculties. We just did a nephrectomy in a tuberous sclerosis patient with multiple angiomyolipomas that were bleeding inside the kidney. So we just removed it. This is endourology surgery. Pretty much we're using a nephroscope to break the stone in millions of pieces. That's the other thing we do. And this is the urolift technique, where we put implant clips in the prostate to avoid doing a big transurethral resection of the prostate, which is like old school. So to finalize, not everything is or we have to study a lot to be able to accomplish all these surgeries and become what we wanted to urology. So if you have any questions, I'm happy to talk to you guys.
Thank you, Dr. Rodriguez.
Yes,
you had someone, Bianca Rodriguez, on here. Is she your program coordinator?
Yes, correct. Bianca
is. Okay. For students, kind of a trade secret, program coordinators are absolutely important, essential people, certainly for program directors. But when you interact with residency programs, when you get into the actual process of applying to residencies, you will interact with program coordinators, and they will hold your life in their hands. They're very important people, and you know, in all respects. So we had a few here this evening, and thank you for your presence. Bianca, do you have anything to add to Dr. Rodriguez's presentation?
No, feel free to navigate to our Utrgv urology website. There's a lot of information on there. If anyone has any questions, even after this meeting ends, feel free to send me an email. I'd be more than happy to sit down and talk to each of you.
Very good. Thank you. There you go. Any final questions from students about urology, the opportunity in urology at DHR? Relatively new program, but off to a strong start, and obviously lots of great things going forward.
Thank you.
Okay. Thank you. All right. Next, we're going to go ahead and learn about psychiatry. And for that, we have Dr. Diana Chapa here, I believe, and Yvette Torres. Yvette, I haven't seen you in a while. Program coordinator? Yes. Okay, another key person that medical students need to know, especially if you're interested in psychiatry. So welcome, glad to have you here. Dr. Chapa, go ahead.
All right, thank you. Thank you for having us. And I couldn't agree more, Dr. Fish, that program coordinators are absolutely key and very important, even as an attending, a staff person. They do so much for us. So I'm also very new, so please forgive me. I'm just learning the program, have not been here even for a full month yet. And so, but as everybody else, have a passion for this field. And so I thought I'd give it a go with Miss Yvette Torres, who is there to help me. She's got my back on this. So anyways, next. So we graduated our first class of residents just this past June, 2021. The psychiatry program has been accredited since 2015. So I think that, again, just like everybody else has been saying, relatively new program, and great that it's already, being so new that it's already received accreditation. So I think that speaks for all the efforts that have been going on here. Next. So just like, again, everybody else, why choose psychiatry? So I think for me, one of the things, and research is bearing that out, that really mental illness is essential to an individual's overall health and productivity. Really, mental health is the fountainhead or the foundation of an individual's daily function. And without good mental health, daily thinking, communication, learning, and resilience become impaired. And if you think about it and you look at that, really, that means that just simply getting through your day becomes very difficult. And so again, that's the beauty of psychiatry. That's what we work with. And we apply medical, cultural, psychosocial knowledge to the treatment of the patients in a manner that brings hope and improvement to the person's overall health and quality of life. And it can be as basic as, like I said, just having them be able to get to a place of health where they can make it through the day safely and without, the need for much support. I've worked with many patients, both from adult to child, and I can tell you with good psychiatric care and treatment, I remember one of my cases was where the patient was partner in a law firm and became impaired, started to suffer psychiatric illness, and the partners brought this patient to our care, to the clinic there for some care and treatment. But again, it impacts all of us, regardless of where we're at in life. And so I think, again, very critical that we do remember that we apply all of the skills that you learn as a medical student and that we learn in our internship year, which focuses on the medical issues that go into psychiatric illness. So our program aims to produce knowledgeable and skilled psychiatrists, just like, again, all the other programs have said. We want to help develop and educate the best of the best. And so we want to have psychiatrists who have a solid foundation in clinical and educational, along with administrative and scholarly aspects of the practice, because we want to help build a lifelong passion for learning, because in this field, regardless of what discipline you're in, I think that's something that's really key to the success of any physician. We also want psychiatrists who are compassionate and altruistic, have ethical and professionalism. They know how to collaborate and advocate for their patients so that they get the best outcome with their treatment. Psychiatrists who are interested in working with a range of populations, and in particular, as has been mentioned, the underserved. So that's a big draw and a benefit to this program, again, that we have the privilege of really being able to provide the care that's been needed for so long to the residents of the area who have for so long been underserved and have also had very limited resources that can, provide them with what they need. We want psychiatrists who are really self-motivated, can be and function independently, can start to look at the problems and the issues, outside of the box, and can work towards solving problems. I think that's the beauty, like what people are saying, or what I've heard other colleagues here say, that that's the draw to being in this program. It's that, again, it's a new program. You're going to be able to be involved in developing it. But I also think psychiatry is a field where we still are very much evolving. Our interventions, interventions such as, transcranial magnetic nerve stimulation, and being able to provide treatment with other than medications and therapy is really evolving and growing. And so again, we want individuals who can begin to understand, look at this, and start to think of what other ways besides what's been there can we begin to deal with the symptoms that our patients have. We want psychiatrists who, again, like I mentioned here, can use the technology and the resources that are there effectively, and also that aspire to be leaders in the field of psychiatry. So I think, again, because like I mentioned, I'm not familiar so much with what all is in the area here. So I think I will let Yvette kind of talk about about the campuses, because I think she's more familiar with them. So Yvette.
Sure. So for those who are not from the Valley, who are in the audience, we just want to point out that our medical school is located, has two large campuses for the medical school in Edinburgh, and the other one's about 40 miles away here in Harlingen. Our main campus for psychiatry, we are heavily based right now in terms of the residents themselves here in Harlingen, and we're developing our clinics in Edinburgh as well now. Some of our faculty is already based there. But we are regional. This is a regional medical school model. So the next slide will show you our clinical sites, which are located across the Valley, including our own UT Health Rio Grande Valley network of clinics. Those are regional. They were established to be all over this 3-county region. Our Rio Grande State Center has as the state mental hospital. It also has outpatient services. We do our primary care rotations in partnership with them. And they're located here in Harlingen. Tropical Texas Behavioral Health is another key partner for our program. And they have locations as well all over the Valley. They do have facilities here in Harlingen. They have them in West Laco and other towns across the valley. We tend to rotate out of those two facilities, and actually our emergency rotations are out of McAllen with them. So it's three main sites for us with this particular partner. The VA administration, Valley Coastal Bend System, is another integral partner for us. And they are located right next to us here in the Harlingen campus. The medical school actually leases a part of the building to them where they have their outpatient services for veterans. Our other main partner is Valley Baptist Medical Center. That's part of Tenet Healthcare nationally. And our main site for psychiatry is here in Harlingen as well, across the street from this campus. Border Region Behavioral Health Center, Coastal Plains Community Center, and Nueces Center for Mental Health and Intellectual Disabilities are rural, are very rural, like the most rural areas in Texas. And actually, we are now directly serving these three sites via telepsychiatry. This is done, Texas has been very progressive in providing line item funding for mental health services, and knowing that there is a shortage of psychiatrists, they are funding 4 different things. And they are providing that funding to psychiatry departments across the medical schools in Texas. The initiative is called the Texas Child Mental Health Care Consortium. And we participate in this arm directly. Our senior residents provide services to these centers as part of workforce development to the most rural areas, hoping to recruit more psychiatrists to serve these very underserved regions. And so our residents get exposure, as do any of the residents that are training here in Texas through that state funding. They're also funding the development of child adolescent fellowships, and that's in the works for our program. Another arm they're funding is research. There are actually 2 actual trials occurring across Texas, and our residents get to participate in that through our residency program. Again, and I'm going into it because of the funding that's linked here, but it's linked to all these other parts of our residency experience for our residents, which is fabulous because that is unheard of in other states. I will punt back to Dr. Chapa so she can talk about core requirements.
Thank you, Yvette. So then on this slide, what you see is just, like the outline of what are the ACG requirements. I'm not going to go into them, but again, you can see what are the ACGME requirements for psychiatry residents to graduate. And I believe that, like in the next slide, Yvette, you have the like broken down more specifically. So as far as the rotations per class, so again, the PGY1 focuses more on medical and neurology for their first year. So those are the rotations. And then you start, and then you also start with inpatient psychiatry, but primary care and neurology are the medical rotations. And then as a PGY2, you continue with inpatient psychiatry. You begin also rotations in the other subspecialties within this discipline, like consultant liaison, geriatric psychiatry, child and adolescent, substance use. We do have psychotherapy, which I think is great, and another benefit of this program, because again, even though the role for psychiatrists has been narrowing more to the biological side of it, more medication and some other types of intervention, I think still it is important that we get some psychotherapy understanding, because I always say our interventions may not necessarily be like going in and doing surgery or, administering some injections, but our interventions, one of our major interventions is the words that we use and how we apply them and how we deliver them. And then they have 1 month of elective, an elective rotation. PGY3s, we, again, that's where they focus more on their outpatient year. So looking at rotations through clinics where they can focus more with the adults. Again, psychotherapy continues. There is a first episode Psychosis and mobile crisis outreach team. So again, it's I believe that's through Texas Tropical, right? And so with the mobile crisis, they actually go to the patient's home, or they can go to, I believe they've even gone to like emergency departments where there is some psychiatric crisis occurring, and the team then can help deliver some care and intervention. They also begin to learn skills and how group therapy works. There's also research that can happen and a rotation that can happen at that point in time, and continued electives. And I apologize, I don't know if you know this, Yvette, but again, as I said, I'm learning the ins and outs of the program. So I'm not sure where all the electives are at. So I can't do as good a job as my colleagues previously did to say where all those electives are at. But we do have those electives, but the purpose of the electives is, again, if you have a stronger interest in geriatric psychiatry, let's say, then you can, do more, spend more time in those rotations. We do have the telepsychiatry, and again, you can do 1 month in the adult inpatient, and the purpose of that is kind of like the basis of what was mentioned before, where it's a chief resident focus. So again, the chief residents there have the opportunity to be leaders and to, be educators. And so that's the focus of that one. Next. So in addition to the rotations, we do have Fridays, we have our afternoon, that's protected time so that we can have didactics. And again, the didactics are taught by our faculty, and with the focus of supporting what's going on with the rotations, and again, helping you develop as a physician, a psychiatrist. And then we have GME weekly grand rounds, psychiatry monthly grand rounds. We have the journal club, and then we have psychiatry, psychology joint case conferences. So that has to do more with the psychotherapy that goes on. We are looking at developing like M&M rounds. So where again, we have opportunity to discuss our more severe cases. And so again, part of developing the program, those are just some things that I think will be coming forth. So many of our, all of our graduates from this first class, again, everybody was very excited. They went on to different fellowships. I think probably, Yvette, you can do a better job because you were here. I wasn't even quite here yet to know where they went to.
So we have 6 residents per class. One of them did get hired to the VA. I was just highlighting the fellowships, who's going on to develop even more expertise after their rotation experiences here, their training experiences. We did have one go work for the VA of the 6, and then the 6th one actually had left us the year before to go. It was the first one to be entering to a fellowship in year 3, so didn't finish 4 with us. But of last year's cohort, which were 5, 4 of them decided that they wanted to continue on to geriatric psychiatry. They got into UT Southwestern, addiction psychiatry. That one went to Baylor College of Medicine. Another addiction psychiatry at UT Austin Dale Medical School. Neuromodulation medicine at University of Minnesota Medical School. And then the 3 that left as PGY3s to finish residency and fellowship, all decided to pursue child adolescent psychiatry. So I guess in developing our fellowship program that's, hopefully gonna come in about a year or so, they developed this very strong interest, and they went on to NYU, They went on to UT San Antonio, Long School Medicine, and then one went to Colorado, University of Colorado Anschutz Medical Campus. So we are very proud of those outcomes.
Yes, and I think there is a lot to be proud of here. And then just in respect of the time, I think, is that the end? I think, Yvette, we're at the end, right? Yes. So yeah, there's a lot going on, a lot to be proud of, a lot to be, very excited about as far as what we'll continue to develop in our program. And so we hope that you will join us. Thank you.
Thank you very much. I've been here in the Valley 48 years. The availability of mental health services, psychiatric care, of course, it's pretty sparse in many parts of the country, but here in the Valley, certainly, we could say that up until recently, it's been, severely underserved in the areas of mental health care and psychiatric care. And just in the few years that the school has been in existence and this program has been in existence, to see, all that you have accomplished and the relationships you've built with other agencies in order to provide access to psychiatric care, it's just astounding. So congratulations to you in the program, and wow, it is really very impressive. And again, for students interested in psychiatry, I think although this program has been around for a few years, still it's very new, and you have a chance to be a pioneer.
Very true. Very true.
Any questions from any of our students? And Yvette, you're at the Harlingen Clinical Education Building. We used to call it the RAC building, right?
That's right. Back home.
Yes. So so she can be reached there if you have other questions about some of the program details, and I'm sure lots of guidance in general.
Nina's gonna disseminate our handouts after this event.
Okay, great, good, thank you. All right, thank you, Dr. Chapa, and thank you, Yvette. Glad to have you here. Very pleased. Thank you.
Thank you.
All right. So for our last segment this evening, I'd like to turn to our neurology program. And I think Dr. Dustin Paul is here, and Dr. Dobbs. Great, both of you. Welcome. Dr. Dobbs is the interim program director. Is that right, Dr. Dobbs? And Dr. Paul is a member of the faculty.
Yes.
So go ahead, please tell us about the program.
I'm going to.
Yeah, we can see your slide.
I didn't know I was muted. Can you hear me?
Yes, we can.
Great. All right, well, thank you so much for inviting me to present this evening. Because we haven't started our residency program, it really ties in to our neurology department and where we are now, and then where we want to be in the next few years as we start our residency program, which was approved by the ACGME and the Neurology Residency Review Committee as of earlier this year, April actually. And our goal is to start taking residents in July of 2022. And it will be a multi-site residency program. But let's talk a little bit first about where we are with neurology. So you all know that I came here in 2019, started on July 1st, 2019, to be the first chair of the standalone Department of Neurology. Previously, there was the Department of Psychiatry and Neurology together, but we started a Department of Neurology as a standalone on July 1st, 2019. And what I want to just point out is that we're living in what you would call a neurology desert, where there are a lot of people in our large region of around 1.5 million people who just don't have access to much needed neurological care. And what you're seeing here, by the way, is a poster that was presented at the American Neurological Association as an abstract a couple of years ago about this area of a neurology desert. So people go without care, or they go far away for care if they could. And certainly they didn't have access to academic neurology care before we got here. And so that is really our goal, is to build academic neurology care for the region. But the Valley isn't alone. There's a nationwide shortage of neurologists, although this area, the Rio Grande Valley, has a disproportionate burden and indeed qualifies as having so few neurologists that this is a neurology desert. This shows you the estimated supply and demand for neurologists in 2025, and these numbers are pretty accurate. Back in about 1990, my specialty made a strategic error, and that is they concluded that basically with new neurodiagnostics like MRI, that the era of the localization-based neurology practice was over, and that we didn't need to teach as many people to be neurologists. And also, they didn't recognize that the 1990s were the decade of the brain, and that we were developing novel neurotherapeutics that would drive care and treatment of our patients into the current era, where we're in a state where we are now rather short of the number of neurologists that we need. It's no coincidence that you see Minnesota with a very large Mayo Clinic neurology residency exceeds supply to demand, as does the Massachusetts area, Maryland, New York, with the largest, most established neurology residency programs. You can see Texas on the whole is projected to have a demand 20% or more greater than supply, and indeed it's a lot more than that in our area. So part of our goal has been to create a Department of Neurology that also has the ability to develop neurology training programs that can augment the workforce and make it really a sustainable matter, that we train our own neurologists who then want to live here in the region and practice in the region. I'd hope many times in our department, but recognizing that won't always be the case. I do want to point out here that if you assess the gap with around 20 neurologists in the area, that we have a deficit of 50 to 55 neurologists in the region, just to reach the national ratio, which folks, I'll just remind you that that national ratio is lower than the demand that's needed. Just let that sink in. Meanwhile, we have a lot of neurological disease in the region. So for neurology trainees, really it is a fantastic place potentially to learn neurology with a lot of patients who desperately need you and really need your expertise. We have just a really steady supply, I guess is one way of putting it, of those classic patients that we need to be able to take care of in order to teach residents how to become neurologists. That includes stroke and cerebrovascular disease, epilepsy, enough multiple sclerosis to support at least one multiple sclerosis neurologist, maybe two. Alzheimer's disease is very prevalent here, as are neuromuscular diseases, Parkinson's disease, and we know that we have quite a bit of brain cancer. But for that matter, neurologists treat a lot of simpler things, such as peripheral polyneuropathy, the most common cause of which in the United States is diabetes in adults. And just estimating the numbers, we probably have a prevalence of 462,000 cases in the Rio Grande Valley of diabetes. If you conservatively say that 10% of those will have diabetic peripheral neuropathy, that's 46,000. That's a lot more than we could take care of. And of course, a lot of them won't have painful peripheral polyneuropathy, but they may have other needs related to mobility, et cetera, that we can help them with as neurologists. And they're currently just not getting that help. Additionally, if a student is interested in tropical neurology, this is a place where you could actually see it rather than just read about it. We have cysticercosis, leprosy, which is in part a neurological disease. Syphilis with neurosyphilis and neuro-Lyme disease are all here. And that doesn't even scratch the surface of all the infectious encephalitis cases that we'd have in the area each year as well. So really there's a lot to do from a neuroinfectious disease and public health perspective here as well that you wouldn't find in a lot of other residency programs. But what we deal with now, actually before Dr. Paul got here, I met a family in the hotel where we were staying when I was interviewing who had 2 little boys with muscular dystrophy, and they had to drive 3.5 hours away to get basic neurology care. When I went out into the community and was talking with some of the hospitals about basic epilepsy surgery, they didn't realize, some of them, that was even a possibility. And despite a patient base to be studied, we were unable, we meaning Utrgv, we were unable to participate as a consortium member in a clinical trial for Alzheimer's disease because we just didn't have the neurologists to actually manage it. So whose responsibility is this to work on this and try to fix it and make it better? Well, it's ours. It's ours as the Department of Neurology here at Utrgv. So we want to provide the best neurology outpatient experience and outcomes anywhere in South Texas, and I believe we can do that. We need to raise the bar for neurological disease inpatient treatment through strategic partnerships in the region, which I know we can do as well. Key to this is building a residency program. We'll start with 2 graduates per year, and I think build over time as the department grows to perhaps 5. And a really nice thing is we'll be able to emphasize ambulatory neurological care in our residency. And those who have been through a neurology residency know how precious that actually is to get in a neurology residency, where usually you're very, very pushed to be in the hospital managing hospitalized patients all the time. And we also will be active in clinical and translational research. We've been successful with faculty recruitments for physician scientists, and we expect more. Our overarching mission is to advance the region, the public's region, and the region that is neurological health through patient care, learning, discovery, and communication. We want to provide the highest level, and this goes the same for the residency program as our department, to provide the highest level and quality of neurocare to our patients, to foster new discoveries that lead to improved care, to augment neurological care capacities and services for our communities, which are sorely lacking in that. And importantly, to also be advocates to increase awareness of neurological disease and disease prevention. This is kind of a comprehensive pyramid that shows neurological services. And this is where we were when we started the neurology department 2 years ago. We didn't have a whole lot, really. In green is what was in place, in blue is what we could do through partnerships. And then others are sort of aspirational goals. We really didn't have the primary sources even, a lot of those at that time, let alone secondary and tertiary care for neurological disease. So really we had a lot of work to do. That pyramid has an awful lot of holes in it for what we could do at that time. And look, there's nothing wrong with just being able to provide these things, but not if you're an academic neurology department serving a region with 1.5 million people. You need to be able to provide most of the things in this pyramid and quickly act to be able to do so. So we did. So we added an awful lot of things pretty quickly over the last 2 years. And you can see that, our services that we can offer are really starting to take shape into a real pyramid. And we're actually getting up there into these quaternary services. I kept neuropharmacy as yellow or stage 2 because we're shelling the neuropharmacy in the Institute of Neuroscience for a few minutes. a few months to maybe a couple years. The reason being, in order to actually support this innovative neuro-specific pharmacy, we just need a higher volume of patients and more neurology faculty and residents to actually really be able to support that pharmacy. We've got the space for it. We've got it set aside. We're just not opening it just yet. But we have an infusion center. We have advanced neuroimaging. We're able to deliver comprehensive care in most neurological conditions. And we really are pretty far along in building that comprehensive pyramid that any department of neurology in the United States of America would be proud to be able to deliver. Big part of this is our Institute of Neuroscience, which was made possible by a massive $15 million gift from the Valley Baptist Legacy Foundation. Here's the architectural rendering of what it will look like. And it's already taking shape really well. This was a few months ago with the building coming together back in about February. The whole first floor is neurology clinic space, and the neurology department space is a substantial part of the second floor. We'll be opening in November. We're also going to have a vestibular lab, which is really nice for the residency program because residents get a lot of dizzy patients, and we're lucky that we have a neurotologist, Dr. Brian Perry, who's more than willing to consult on and teach the residents about their dizzy patients and teach them how to assess them in the vestibular lab. But we have a lot more things than that we're able to offer to our patients, and that includes advanced neuroimaging, which you see right there behind us in the photograph. Almost ready to open. And this is our department right now. We have 4 full-time faculty members. We also have a lot of community-based faculty members who are really important to teaching our students and will be important to teaching our residents. But we do intend to have a strong, sizable academic neurology department of our own faculty, our own full-time faculty, because the community, the region needs us to. And that's our office space where we are right there. It's going to take shape, and that very room right there is where the residents will have their personal spaces as well. This is our residency program director. This is a picture of Dr. Hack from a few years ago. He looks just a little older now. That's when he was completing his movement disorders fellowship at University of Florida. Dr. Hack is a nurse by background. He was my resident at the University of Kentucky. And then I helped to get him a fellowship in movement disorders at arguably the best program in the country, the University of Florida. From there, he entered the US Navy. Dr. Hack immigrated to the United States, and he told me he always felt a great debt of gratitude to the United States and wanted to do something in return. So he actually has served in the military on his own, just he chose to, didn't have a scholarship, he just chose to for a few years. He's getting out though, because he feels it's time and he feels it's important to provide ongoing service to a region of the United States, and the area that he picked was ours, right here in the Rio Grande Valley. So he's going to be the residency program director. He's extremely excited about that. And he'll also lead development of our movement disorders program, clinical program as well. He will join us this winter. So we'll have a multi-site residency program starting with 2 residents per year. The PGY 1 year is an awful lot of internal medicine. We'll have some family medicine in there too. Plan for a month of neurosurgery, a month of psychiatry. Throughout the residency program, we'll rotate it. We'll rotate our residents at multiple hospitals and clinic sites throughout the valley so that they'll get to see the entire community and the types of neurological diseases in many different places. The home base will be at the Institute of Neuroscience in Harlingen, where they'll also have their continuity clinic and be able to do some specialty clinics as well. Of course, the goal of our residency program is the success of our residents, which leads to the success of our department and the success of our region, and being able to offer comprehensive, advanced academic neurological care. I feel like I went a little bit quickly, but we're just getting started. So I'd love to take any questions or hear any comments from the group.
Thank you, Dr. Dobbs. So if I understood correctly, are you all now going to be looking at applicants from students this fall and winter and accepting some by match day next year to start next July? Is that
Well,
right?
our goal is to start next July. As long as one or two little dominoes fall into place, that will happen.
Okay.
So that's our plan. So please look for us this fall.
Yes. Any questions from students? And, again, it's amazing, how much has come together so beautifully in a relatively short time. But it's going to be absolutely tremendous, what this will offer the residents here of the Valley. It's going to be tremendous.
That's true. That institute alone, just for perspective, some of you all may know University of Cincinnati and UC Health. Very mature neurology program there with around 70 faculty. They just now got to build a neuro institute, and they got the same $15 million gift to build that in Cincinnati. So they waited like 60 years before they got that, and we got that as our starting point. So that's just, it's I don't know how to describe it. It's much more than extraordinary.
Yes,
But
absolutely.
we have a great team, and they really make things work.
Right. Dr. Paul, did you want to add any comments?
Dr. Dobbs pretty much covered all the components for the neurology residency program. The only other things at the goals are to train you to be a good general neurologist. There's lots of different fellowships and opportunities if you choose a career in the other subspecialties. There's movement disorders, cognitive, neuromuscular, clinical neurophys, epilepsy. So the goals of our residency program to be a well-rounded general neurologist. But there's lots of avenues in your career if you decide to go into a subspecialty of neurology as well.
Yeah, and in good time, we'll have those fellowships, maybe sooner than we think.
Any questions from our students? Okay.
A quiet group.
Quiet group. Thank you, Dr. Dobbs, Dr. Paul, for your presence and your presentation tonight. Thank you very much.
Thank you for the invitation.
Well, folks, thank you. This is the first of 3 sessions showcasing our Valley residencies. The next session will occur on Monday afternoon, starting at 5:30. We will showcase our 3 family medicine residencies here in the Valley, plus the Driscoll Pediatrics program, with whom we have a nice relationship. So that's coming up on Monday, the 9th, and then the 3rd session later in the week on the 12th, where we will talk about internal medicine and our transitional year offering. So we'll send you out reminders about those. So thank you all for your being here this evening. Nina, Melody, thank you for putting all this together for us.
Thank you, Dr. Fish.
Very
Have a
good.
good evening, everybody.
Yeah, and this session was recorded, so at some point you all have it for reference if you want to go back to look at it. Okay. Good to see you, Yvette. Have a good night. Thank you all.
Bye.
All right, thank you.